This is Professor Ndubeze Okonkwo. I'm a biochemist and I'm a specialist in internal medicine. I'm a subspecialist in nephrology, which is kidney and hypertension. And I'm also a ultrasound specialist in transplant medicine, specializing in kidney and pancreas transplant. This is a short video on stroke, aka cerebrovascular accident. It became of serious interest to me yesterday after I spoke to a family in Nigeria concerning their mother who had a stroke and had been in the hospital for the last 2 weeks. The case of this patient is a 65 years old black woman who has a history of dementia, and dementia is memory loss that is chronic. They don't know why she has dementia, and hopefully by the end of this video we may be able to extrapolate from the information that the likely cause of her dementia is multiple strokes. And this kind of dementia, we call it multi-infarct dementia. She had a stroke sometime last year, but did not have any deficit, meaning the stroke did not cause her to lose any function. The arms were doing well, the legs were doing well. She was able to maintain activities of daily living, eating and bathing herself without any difficulty. The only problem they said she had was the memory loss. So she had a stroke 2 weeks ago and has been in this hospital in Nigeria, lying in bed, basically with no treatment except that she has a nasogastric tube, which is a tube they put into your nose that comes down to the back of your mouth and goes straight into the food pipe, into the stomach, so they can feed the patient to prevent her from aspirating the food into the lungs if she tries to eat by mouth, because the brain is no longer coordinating with the mouth. And so when she wants to swallow, she may end up swallowing the food into the windpipe instead of the food pipe, which is the esophagus. So we have two kinds of strokes in terms of classification. We have one class called hemorrhagic stroke. And what it means is the brain has an infarction, and then you bleed from the blood vessel inside your brain, causing you what we describe as stroke. So we call it hemorrhagic, which means the stroke that bleeds. Then we have non-hemorrhagic stroke, the one that does not bleed. And the non-hemorrhagic stroke, we break it down into what we call thrombotic stroke and embolic stroke. And in a short while, I'm going to tell you the difference. What are the most common causes of stroke? There are many, but we can somehow summarize the most common ones. And there are: one is hypertension, the other is diabetes, the other is smoking, we have alcohol consumption, and we have what we call connective tissue diseases or vasculitis, meaning when your blood vessels have any kind of disease causing it to inflame, the blood vessel can rupture and the patient can end up having a stroke. Another cause is sickle cell anemia, which is very common in Nigeria. Another is high cholesterol. And there are many others. This is just a summary. Sometimes if you have a kidney problem and you lose a lot of protein into your urine, some of those proteins are things that keep your blood to be thin. if you lose them, you have a tendency to uh, clot your blood. And so when you clot your blood faster than an ordinary person or a normal person, you may end up having a thrombotic stroke. Um, or you can have a clot somewhere in your heart, and that travels from the heart to the brain, and that is an embolic stroke. So the difference between embolic stroke and thrombotic stroke, one is that the blood vessel that brings the blood to the brain, because the way it works is the heart pumps out the blood goes into the biggest blood vessel called the aorta, and it's going to divide into different branches, like the branches of a tree. And one branch called the carotid artery, you have one on each side of the neck. They will bring blood to the brain, and then when they come into the brain, they're going to divide into multiple branches, again like the branches of a tree that will have more branches as it travels. If any one of these branches break open, which is the artery, then you lose the blood into the brain. And since the brain tissue, the brain itself does not get blood supply, because it's like the pipe that controls running water in the city. If the pipe breaks or ruptures, water is going to be running all over. It's not going to get to the destination. If the destination is your garden, then your plant dies. So the artery does the same way. When the artery is bringing blood to the brain, if any one of them ruptures, then it won't bring blood to that portion of the brain. And any portion of the brain that does not get blood, within minutes, especially if it goes up to 12 minutes, that particular portion of the brain will sustain irreversible damage. On the other hand, there is more to this than just 12 minutes. In a short while, we're going to get there. So when somebody has an embolic stroke, which means a clot came from somewhere to the brain, causing the artery to be plugged, and the blood won't pass through, therefore that portion of the brain dies. And that's what a stroke is. You can call it a brain attack, or cerebral infarction, or you can call it what we say cerebrovascular accident, or you can call it a stroke. Any one of them is a good terminology. So when the blood clot comes from, say, somebody has a irregular heartbeat called atrial fibrillation, in which your heart is not beating the way it should, blood clot can form in one of the chambers of the heart. And when the blood is pumped out of the heart, the clot will travel with it and go into the circulation and then travel to the brain and will block one of the blood vessels, and the person has a stroke. So in this case, it is the clot in the heart that is causing the stroke, but the damage is done in the brain and not in the heart. A thrombotic stroke is where you have a cement-like deposit inside your blood vessel called plaque, and it's like cement made up of cholesterol and calcium and other molecules, making it difficult to maintain a patent lumen, which means the artery is not wide enough to allow all the blood to pass through. So that location is stenosed, or is narrowed, because of this plaque. So if you remove the plaque, you have blood flowing through. But if the plaque is there, you have small amount of blood passing through, and if not enough gets through to the brain tissue, that portion dies, and we call that stroke. So in this case, it's called thrombotic stroke, because the initial pathogenesis, what causing it is development of this thrombosis at that location, which is the narrowing of the artery at a particular spot. It can be all along the entire lumen of the artery, or it can be in its segmental form, meaning different segments of the artery. So that is called a thrombotic stroke. You're going to see that there's a difference in the way we treat them in a short while. And so the hemorrhagic stroke is somebody who has, for instance, has high blood pressure, and that pressure is not treated. The person is not aware that he has high blood pressure. Then the blood vessel ruptures in the brain. When it ruptures in the brain, then the brain tissue does not get the blood that it needs, and then it dies. that portion of the brain, when it dies, the portion of your body that it controls also dies. For instance, if somebody is right-handed, it is the left side of your brain that controls your right side. So if you see someone who has a stroke and the right side is not working, then you realize that the blood vessel that has a problem is on the left side of the brain. Okay, so if the blood vessel on the left side of the brain ruptures, then you end up having stroke that affects the right side. If one is unlucky and you have major blood vessel rupture that can affect both sides of the brain, then the person becomes quadriplegic, meaning your arms and your legs are both going to be paralyzed. That's very rare in a sense. When you're dealing with stroke, there are things that can cause that, but a stroke can, is one of them. So when someone has a stroke, and either you are told the person has a stroke and the patient is brought by ambulance to the emergency room, if you happen to be in the emergency room and the person receiving the patient, you are going to know very quickly within few minutes of examining the patient and in getting the history, because it matters. The history matters, as well as the exam that you're doing also matters, because if the history is the person has hypertension, has diabetes, has high cholesterol, smokes, drinks, this person has many risk factors to cause a stroke. So if this patient is unable to speak to me, I have to assume that maybe he has a stroke. The next thing is for me to examine the patient. If I examine the patient and I recognize that the portion of the body is paralyzed, that this is stroke until proven otherwise, or the patient is unable to speak to me because the part of the brain that deals with speech is damaged by the stroke, or the patient, as you're examining the patient, you see the person is blind because the portion of the brain that controls the eye and vision is equally damaged. So if the exam tells me that this patient has a stroke, or it gives me a suspicion, what we call presumptive diagnosis, then I'm going to send the patient immediately to radiology to get imaging, which we call CAT scan without contrast. So we do CAT scan with contrast, and we do CAT scan without contrast, and then we do MRI, MRA. There are different kinds of imaging, and we start with the most useful one and the most definitive one at the end of the day. Excuse me. So the first thing I do is I do the CAT scan of the brain. If the patient has hemorrhagic bleed, then I'm going to see the blood. Once I see the blood, then I know that this person has a stroke confirmed, and the stroke type is hemorrhagic, the one that bleeds. If the patient has normal CAT scan, which means I don't see any bleed, but the examination shows that the patient has paralysis, it's still okay for me to make the diagnosis that the patient has a stroke based on the history. If somebody was doing well 5 hours ago and all of a sudden can't speak now, can't move the arm, can't move the leg, that's a stroke until proven otherwise. And why it is necessary to make sure you make this diagnosis very quickly is that for somebody who is paralyzed, but what he has is a thrombotic stroke or embolic stroke, you can treat that and the person recovers. And there are techniques to treat that. One, we can use medication called the thrombolytics. We can say thrombolytic therapy, meaning clot busters. So we use this medicine to go and dissolve the clot that formed, which block the blood vessel and the loss of blood supply to the brain. If you succeed in doing that, most often than not, if it's done within 3 hours of the onset of the stroke, the patient recovers. And that's a win-win situation. And you are a magician by the patient's interpretation. A few minutes ago, I was paralyzed, now I'm not. If you're unable to do that with medication as a result of certain risks, because the medication itself carries a risk, you can bleed in other parts of your body by using that medicine. You can bleed more in the brain also. So if there's a high risk in doing so, or you have gone past the window, which means your well-known time was more than 5 hours before I see you, then I'm going to have to send you to a neurointensivist or interventional radiologist. They can advance a catheter through the arteries and get to the brain and extract that clot mechanically, which means they will remove it using an instrument, and then that will reestablish the blood flow to the brain, and then the brain recovers, and then the stroke vanishes. When someone has symptoms suggesting stroke, like you're not talking, you're not speaking, or your arm is numb, um, or you feel tingly, um, but it recovers by itself within minutes to hours without any deficit. And when we do a CAT scan, we don't see anything. We say you have a transient ischemic attack, meaning you had a stroke that was beginning to happen, but ended up not happening because your body corrected itself. Because the body has a way to generate its own medicine to dissolve any clot formation until it's overwhelmed, and then it can't help you. Then you need outside intervention to solve the problem. What are the symptoms of stroke? Somebody that's been talking to you, you're playing with the person, and all of a sudden it goes, "Oh, um, my hand is weak, my leg is weak," or you see the person can't speak anymore, or he's speaking but it's not making sense, um, which means the patient is incoherent. He may not understand what you're saying, or he wants to say something to you, but he can't say it to you because the part of the brain that controls speech is affected by a stroke. So when you see somebody who has speech change, visual change, tingling, numbness, focal weakness, meaning a portion of the body is weak, the arm or the leg or both, these are symptoms of a stroke. Or it can also be severe headache, can be nausea and vomiting, because when you have a stroke, it may increase the pressure in your intracranial space, which is within the skull, and that may cause you to vomit. Or somebody has a bleed, the bleed increases intracranial pressure inside the skull. It can make the person vomit, and so vomiting, nausea, headache, dizziness are all symptoms of stroke, in addition to what I had described earlier. And somebody can be having chest pain and shows up for chest pain, and you recognize this person has atrial fibrillation, which is a certain kind of irregular heartbeat, and then it tells you I have dizziness, I have headache, but nothing else is going on. You do an EKG, electrocardiogram, and the patient has atrial fibrillation. You can quickly go and get a CAT scan of the head to make sure he hasn't had a stroke, and then you need to treat the atrial fibrillation to prevent the patient from having a stroke. That's a different topic altogether, but in that case, you need to thin out the person's blood so it doesn't form a clot in one of the heart chambers. After I do this CAT scan, what are the other things I can do? If I do the CAT scan and I'm unable to find any evidence of stroke, even though the exam tells me you have a stroke, or the history is suggestive that you have a stroke, then I can advance to what we call a CTA or CT angiography of head and neck to look at the big blood vessels in the neck and in the brain looking for a clot. If I'm unable to find that, I can go ahead and do an MRI or MRA. There are reasons we choose one over the other, but MRI is the definitive one. If I do an MRI in a place I suspect a stroke and I don't see any evidence of stroke, the chance that the person had a stroke is extremely remote. And of course, you need an echocardiogram if somebody has irregular heartbeat, so you can see whether the patient has a clot formation in one of the chambers or the valves, which is going to embolize to the brain or travel to the brain. EKG is part of that evaluation, which is electrocardiogram, as well as a chest x-ray, because somebody may have cancer of the lungs, and that cancer can precipitate a clotting mechanism in which a patient can form clots anywhere in the body. And if form the clot in the heart, or form it in the brain, or form it in anywhere else and it travels to the brain, that can cause you a stroke. So those are parts and parcel of workup for the stroke. We get some labs to help us, such as complete blood count, lipid profile, which is looking at your cholesterol level, what we call complete metabolic profile. We want to see, does this person using CBC, does he have low platelets? Platelet is the part of the blood cell that helps you to clot your blood. So if you have a very low platelet, it's going to be difficult for us to give you clot busters, because if we do, you're going to bleed out. And so in a nutshell, this is the summary of symptoms of stroke, how you can make a quick diagnosis, the most common causes of stroke, and the labs and the imaging that you do to determine whether a patient has a stroke or not. And of course, if the patient has any of these things that cause stroke or associated with stroke, you have to make sure you treat them in advance to prevent stroke from happening in the first place. So if you control your blood pressure well, the chance of you having stroke for hypertension is remote. Same thing applies to diabetes. If you treat it well over time, if you don't, you're going to form thrombosis through different mechanisms in different parts of your body, including the brain, by what we call formation of atherosclerosis. If you're a smoker, you'll be advised to stop smoking. If you're alcohol consumer, you'll be told to stop if you wish, but advice will be given to you, but the choice is yours. If we treat you to make sure your cholesterol is normal, if it's high, we'll give you medicine to control the cholesterol level, and also advise you on how to eat to prevent high cholesterol in the first place. And even if your cholesterol is not high, if you have a severe atherosclerosis, we tend to put you on anti-lipid agents such as Lipitor. In some cases, it will prevent you from having more formation of atheromas, and in some cases, you will even regress the atheroma that has been formed, making it less likely for you to have stroke in the future. The reason I ran through this summary very quickly is to show that when somebody has a stroke, you shouldn't just take the person and put him in the bed, and that's it, which is what they were doing for this lady in question. She's been in the bed for 2 weeks, no physical therapy of any sort, no imaging of any sort except CAT scan, no echocardiogram done. None of these tests were done except the blood test and the CT, which is CAT scan of the brain. And they said because they didn't see any stroke, any bleed in the brain, there was nothing more to offer. Well, if somebody has a hemorrhagic stroke and has a lot of bleed in the brain, part of that treatment is opening the skull and evacuating the blood. Otherwise, the person may die from it because the presence of blood that wasn't supposed to be there in the first place increases the pressure inside the skull, we call intracranial pressure. And then that can cause a mass effect, which means it can push the brain from one side to the other. There's a straight line that separates the brain into two halves. If that straight line is pushed on and it moves away from where it's supposed to be, that's a very dangerous thing to see when somebody has a stroke. It's called midline shift. When there's a midline shift, 9 out of 10, it's because of mass effect, and you have to remove that mass to prevent a further shift in the midline, and then prevent the person from dying. Because you can see somebody has a stroke, you're talking to him now, in the next few minutes, the person is dead. Why? Because intracranial pressure becomes too high. It will push the brain out of the skull through the neck. There's a hole between the head and the neck. It's called the foramen magnum. Once the area that controls the breathing exits the skull, you die immediately. Okay. So this patient, I recommended to them for aid to start the patient on antiplatelet, put the patient on a blood thinner, especially when the patient does not have a hemorrhagic stroke. In this case, the patient needs to be on aspirin or Plavix, both of which are blood thinners. In some cases, we may advance to what we call Eliquis or their brothers, a stronger blood thinner. There are many reasons to select one over the other. If somebody has embolic stroke from atrial fibrillation and the person is less than 75 years of age, he needs Eliquis and not aspirin. And etc. There are indications for one over the other depending on the scenario and the case of the patient in question. So this patient I just described, they should start the patient on anti-lipid agent. They should give the patient aspirin or Plavix. They should, of course, run these tests that I enumerated here to see if they can find a source of that stroke that is correctable. And then they need to start physical therapy. Otherwise, if they leave the patient there, the joints are going to be stiffened and they will contract. And if the patient starts, if you're not moving the patient and it starts developing bed sores, bacteria will enter through the sore and cause the patient sepsis. The sepsis can kill the patient after he has the stroke. And then they need to do speech therapy to see whether the patient can swallow or can't swallow. Because the patient can't swallow, you can't feed the patient, because if you do, the patient is going to aspirate that food into the lungs and he's going to die from aspiration pneumonia. It's like you're choking the person dies. the other things you can do for the person, supposing the problem is the heart, then you treat whatever is causing the atrial fibrillation. In some cases, it may require surgical intervention called ablation. Other times, it may just require cardioversion, where you shock the patient and shock that rhythm back into place. Or if you can remove the AFib, you control the rate, which means the speed at which the heart pumps. You slow it down with medication called beta blockers. If you want to control the rhythm, to bring the rhythm back to place, if you can use medicine. There are certain medications such as calcium channel blockers like cardizem to regulate the rhythm. If you succeed, that's the end of it. If you don't succeed, then you advance to cardioversion. Cardioversion doesn't work, then the next step is ablation, where you advance electrodes into the heart chamber and go to the source of that irregular rhythm and ablate it. And when you do so, you may succeed over 90% of the time. In general, it's somewhere around 70 to 90%, depending on different literatures. So that's the summary of stroke. I don't think it's okay to have somebody who has a stroke and have him or her sit in the hospital day after day doing nothing for the patient. You don't have any of these imaging techniques. You don't have any of these treatments. You have the person sitting in a place you call a specialist hospital in one location or the other in Nigeria, when the treatment he needs is in a different location. And the ideal thing to do, transfer the patient to where the services he needs are available. So I hope this helps. The purpose of this is not to do an extensive presentation of stroke. It is just to give a summary so that one would know if somebody has a stroke or has symptoms of stroke, you can recognize it and what you need to do immediately. If you're in the United States, where things work very well, you call 911. The ambulance shows up, they can diagnose the patient very quickly, bring the patient straight to the hospital, straight to CAT scan before they bring the patient into the emergency room. And then if the person has severe hypertension, the physicians will treat that. They'll find the etiology and then and deal with it. But if it happens to your folks in Nigeria, just remember that all hospitals don't have what it takes to treat a stroke patient. So be astute. If you have somebody who has a stroke in Nigeria, please think about teaching hospitals. That's where you have comprehensive care, or hospitals that are equivalent to tertiary hospitals like teaching hospitals, or hospitals that specialize specifically on stroke. That's all they do. So there's one in Owerri area by Dr. Anyanwu, who used to be a neurointensivist here in the United States before he went back to Nigeria. I'm very impressed with the work they have done on 2 patients that we have sent to them. And this is not an advertisement for them. I'm just telling you what I know. If you can send your patients to any place of your choice where you believe or know that what they have is what your family member or your patient needs. And this is to promote quality healthcare in Nigeria and then give this information to the community for better decision making. I hope this helps.